tonight's forum. My name's Karen Price. I'm the Director of HIV and Sexual Health at ACON. And, before we get underway, I would like to invite the delightful Auntie Millie, who's a regular at ACON events, really, giving us an official... Auntie Millie is an elder from the Wyanga Aboriginal Aged Care Program in Redfern. Thanks, Auntie Millie.
Thanks, Karen, and because I've had a long relationship with ACON, I'll say good evening, friends, to everybody. It is my honour to be here tonight to welcome you to your forum to enlighten people on the new drugs that help prevent AIDS. I thank ACON for allowing me to share in your achievements over the years, where they have worked to improve the lives of LGBTI people and the community, and I'm happy to have been a part of that for the past few years, and I see Mark here tonight. Hello, Mark. I would like to briefly explain the history of Welcome to Country. Despite the absence of fences or other barriers, Aboriginal people have very clear geographical boundaries separating one language group from another. Prior to colonisation, there were approximately 600 different language groups across Australia, all with their own boundaries, a great many of which still exist to this day. One had to receive a welcome from the host country to ensure safe passage on and across the land. I am from Wiradjuri country in central New South Wales, and it's proper protocol for me to acknowledge and pay my respects to the Gadigal people of the Eora Nation as the traditional custodians of the land on which we stand. For those of you who may not know, the Gadigal are one of 29 clans which make up the Eora Nation of the Sydney Basin, which is bounded by the three great rivers surrounding Sydney, the Hawkesbury to the north, the Nepean to the west, and the Georges River to the south. I pay my respects to all of our elders, yours and mine, past and present. I'm always happy to do the Welcome to Country, as it is in accordance with my commitment to the process of reconciliation between the first Australians and our fellow Australians, because I believe that the gap between us had been far too wide for far too long. There are over 200 different nationalities from overseas who have settled here over the past 227 years. The Aboriginal people have the unique distinction of being the first Australians, First Nations peoples, and we should always be acknowledged as such, and our ancestors have been here for over 40,000 years. I like the diversity of our Australia today. I like the differences, and I like the different cultures that have been brought here from all corners of the globe. We can all coexist in our great country if we can celebrate our diversity and show mutual respect for each other. Each and every one of us make up the wonderful tapestry which is our Australia today. I do so salute the people working in this particular area. Researchers tirelessly search for solutions. Frontline workers must see so much sadness, but at the same time, know that you're doing a great worthwhile service for the people who you work with. Any new discovery and any service delivery, I feel sure, is rewarding to you all as you give people hope. All people must have hope. I wish each and every one of you here tonight good health and happiness for yourselves and your family, and I hope you have a safe and trouble-free journey home, and may you always walk in safety when you walk on Gadigal land. Thank you and welcome.
Thank you, Auntie Millie. Fantastic as always, and warm, a warm welcome. So look, it's up to me to do a few minutes of housekeeping and a few introductory comments before we get into the forum proper and hearing from Bob in particular. So just wanted to say a few things. One is obviously the exits and the toilets are all out in the foyer for those that need it. I also wanted to let you know we're recording tonight's forum because obviously not everybody who's interested in PrEP lives in Sydney or Darlinghurst. So we've got the lovely Tim up the back there with a video camera. The video camera will be trained upon will be focused on the podium and also the panel. So participants won't be the focus of the video. However, if you ask a question and you later on reflect on that and would like to come and talk to us about editing that at any stage, let me know, let Tim know, or any of the other ACON employees around the room know. That would be great. We also are trying something which will probably be against my better judgment. We're trying technology, and it's an email address. It's not Twitter, it's not a hashtag, it's not that scary. It's www.acon.org.au/PrEP questions. The idea of that is when Bob is speaking, we're not going to actually allow questions directly after his presentation because he's going to be on a forum on the panel, and the purpose of that panel will be a Q&A session. But if a question pops up for you in that presentation or the presentation from Irina that directly follows it, and you're worried about forgetting it, whack it in an email, send it to that. Hopefully it appears on an iPad, and with any luck I'll be able to read it. So we'll see how that works. So thank you very much for attending tonight's forum, which has been called PrEP, Tales from San Francisco. This forum is proudly brought to you by ACON and Ashram, and as you might know, Ashram has a national leadership role to support the HIV, viral hepatitis and sexual health workforce. Along with Ashram, ACON and our sister organisation in Victoria, VAC, we combined forces to bring Professor Bob/Robert Grant out here from California. I'll introduce him in more detail in a minute so you'll understand why that was such an important thing for us to do. And Bob has been really busy up in Ashram, the conference in Brisbane, and also meeting with policymakers and others in the HIV sector to talk to them about PrEP and the experience of San Francisco. So why San Francisco? Well, obviously their experience with PrEP is pretty salient, but also San Francisco is sometimes pretty much compared to Sydney. Sydney, like San Francisco, really was the epicenter of the sexual revolution and the gay rights movement. They have the Castro, we've got Darlinghurst, and we both have sexy bridges. So when it comes to HIV, we've also got some similarities in the sense that both cities have excellent research, clinical and community collaborations and partnerships that have been pivotal to the fight against HIV since the mid-80s. And as I look around the room, I know that I can see a couple of GPs and others that have been in this game for the whole 30 years that we've been around so far. So thank you for your contributions and being here tonight. So tonight's audience is a real mix of clinicians and community, and I'm really pleased that you guys could come. But for all of our similarities, we have important differences, and tonight we're going to learn about the experience of PrEP implementation in San Francisco, something that we are unfortunately not able to talk about from first-hand experience properly yet in Australia, as Truvada has not been registered for use in Australia for PrEP yet, and it has been available for use in the USA since 2012. So aside from a limited number of people who have been enrolled in a research trial in 3 states in Australia, PrEP is largely being imported by some individuals, but it is otherwise not really widely accessible. So tonight, ACON and Ashram have combined to host a forum to talk about the prospects of PrEP, to talk about the potential of PrEP, and really so we can let you all know that we're fighting and advocating and working behind the scenes to make PrEP available as soon as possible. Because we both organisations believe that gay and other homosexually active men should have access to the full range of evidence-based prevention technologies in order to reduce HIV transmission. So tonight we'll hear from Professor Bob Grant. We'll also then hear a 5-minute presentation from Dr. Irina Zablotska-Manos from the Kirby Institute in the University of New South Wales. She's going to talk to us for 5 minutes about the 300 participants enrolled in the New South Wales PrEP trial. And then we'll be throwing to a panel with a range of speakers, and I'll explain who they are in a minute, and engage in a Q&A with the audience. So Bob Grant, who is he? He's had more than 27 years of experience in the HIV/AIDS clinical care and research fields. In 2012, he was named one of Time magazine's 100 most influential people in the world for his groundbreaking clinical trial that was the first to demonstrate the efficacy of PrEP for the prevention of HIV infection. He's had a lot of career achievements, including the establishment of a laboratory for clinical virology in 1997 and a laboratory of molecular evolution, I love that name, in 2000. He's served as a member of the US Food and Drug Administration Antiviral Advisory Committee, and he's authored a very large number of peer-reviewed publications. So I'd like you to join me in welcoming Professor Bob Grant to the podium.
Thank you, Karen, for the very generous introduction, and I'm filled with gratitude for Mili's welcoming us to this place on behalf of the traditional custodians of the land. I think that her granting us safe passage is so critically important at this time, because we're here really to imagine safe passage toward a future possibility where we can seek human connection without having to be afraid of HIV. And we understand that our quest for human connection necessarily brings awesome power and astonishing, frightening events. That's part of our social being. It's part of the way that we connect with each other and we create our realities. We don't need HIV to make us more frightened. We don't need it to limit our possibilities. So we are here today to imagine a world without HIV, a world in which we're no longer afraid of HIV transmission. Before we can proceed, I think we need the welcome and the safe passage, and thank you for that. I think we also need to acknowledge the beautiful people who have gone before us. I can't proceed without first acknowledging the wonderful and beautiful people who have died previously of HIV. And so I would ask us to just take a moment and do what you want with your moment. But for me, I will be asking the people who have gone before for permission to take bold steps to end HIV transmission. Thank you. We have an amazing time of possibility here in Australia. I arrived on Sunday, and Monday I woke up with one prime minister and went to sleep with another. And we also have incredibly powerful tools for ending HIV transmission. HIV treatment, when it suppresses viral load, virtually eliminates infectiousness and prolongs life indefinitely. We know that HIV testing is even more effective. We understand the power of human negotiation and people talking with each other, communicating with each other to create safer and safer relationships. That is a power that social scientists here in Sydney have helped us understand. And we also have something new. We have a pill that, when taken daily, or nearly daily, virtually eliminates or nearly eliminates the chance of acquiring HIV infection. It's called pre-exposure prophylaxis. It's one tablet that contains 2 medications. When taken by people who are HIV uninfected in a regular manner, it reduces risk of HIV to very low levels. In fact, I have not seen anyone become infected who has drug levels indicating use of 4 or more tablets per week. It's highly effective when used. So I'm here to tell you about some of our experience with this concept called pre-exposure prophylaxis in San Francisco. I present it not as my own work, but really as a witness to the community's efforts. The rollout of PrEP was very much a grassroots initiative in my hometown. I discovered it later. And so we'll be talking about the dissemination of PrEP innovations. And I'll touch on a number of topics. How well does oral PrEP work? And the medications we're talking about are a combination of 2 medications, emtricitabine and tenofovir. I will talk about the current scale-up of PrEP in the United States and how it's clear that we've reached a tipping point in demand. People have gone from being unsure of the concept to wanting to be part of this movement. I think it's important to realize that the people who are taking this up are the people who have the most to benefit from it. So it's really, one of the lessons learned is that people can perceive when they need something else to protect them from HIV. I want to talk about the impact on HIV transmission in San Francisco, the scale-up of PrEP, and I want to end by discussing stigma and the way our language informs and recreates stigma almost on a daily basis. So this is a technical comment for this audience. I'm sure you're going to love it. It's important that that everyone understands that PrEP works when it's used. And so how can we be sure how much people are using PrEP? Well, we do have incredibly powerful laboratory tools for that. One of them is the measurement of drug levels in dried blood spots, which can be collected routinely in the clinics. And this is not something that I think should be used in routine clinical practice. Your local doc doesn't need this, but I think to understand our science, to understand our projects, these kinds of measures of actual drug use are important. And the amazing thing about this particular test on dried blood spots is it's sensitive enough to detect use of 1 PrEP tablet per month. And we can distinguish that from up to daily use. So it's an extraordinarily powerful tool. And what has this tool shown us? Well, this is the relationship on the vertical axis here of HIV incidence, or the rate of new infections, higher levels or higher rates of infection. And it's plotted against the concentration of drug. And we've categorized the concentration of drug according to how many tablets we think were used to get to that concentration. And you can see in the green bars there that HIV incidence has plummeted to extremely low levels. And in fact, we did not see anyone in the IPREX open label extension, a demonstration project done in 6 countries around the world. We didn't see anyone become infected who had drug levels that indicated use of 4 or more tablets per week. Even use of 2 or 3 tablets per week was associated with an 84% decrease in HIV risk. And even less use still had some protective benefit, but it was quite modest. The point I'm making here is that PrEP works when it's taken, and it works extremely well. And that even though we recommend PrEP be used daily, we know that people are not perfect, and that some tablets will be missed sometimes, particularly on weekends, times away, during binges or parties. We know that these are vulnerable times when people's lives get disrupted, perhaps in a good way, in a way that favors discovery and connection, but at the same time makes it harder to take and remember to take your pill. The beauty of this forgiveness for occasional missed doses is that if people try to take it daily and they miss a few doses, they're still highly protected. So PrEP works when it's taken. The question becomes, can anyone take it? And as an anecdote, when we first started describing PrEP and the need to take PrEP daily, almost always in an audience, somebody would stand up and say, Dr. Grant, really, be realistic. No one can take a pill a day to prevent anything. And as I reflected on this, it went on for almost a year. Every conference, I must have given 50 presentations or 100 presentations that year. There was always someone who stood up and said, it's just not happening. No one can take a pill a day to prevent anything. And one reflection I have over that year is that the person who stood up and said that was always a man. It was always a man. And the women in the room would sort of look at each other and say, what is he talking about? Been taking birth control pills for 10 years, and I do it. It gets done. And it was someone in my lab. You know, I sort of repeated this. I went back to my laboratory and I said, you know, people think you just can't take a pill a day every day. And my lab director, who's a woman, said, that's not true. I've taken a birth control pill every year for 5 years. Never missed once. I said, okay. So you learn. You learn. And in fact, we see that people can take PrEP every day, or enough to protect themselves to a very high level. And this is data from the US demonstration project showing that 80 to 90% of people who receive PrEP are taking PrEP sufficiently to give them really high levels of protection. Another bit of good news is that in demonstration projects and PrEP services, people tell us how many pills they're taking. That wasn't true in the clinical trials. We had a terrible problem in the course of our clinical science where people would say they're taking every pill, but they were actually not taking any. And in a sense, we created that situation. We created a social contract in which there was a strong expectation that people who signed up for the trial would take a pill every single day. And when they decided at some point that they were not going to take a pill every day, they felt badly about that, and they told us they were still taking a pill when they weren't. And I think we set themselves up for that because we insisted that everyone has to take a pill every day. That's not the way we practice medicine, at least not on a good day. On a good day, we say, my recommendation is that medicine is best used daily, but you are in charge. And you need to tell me how you're willing to take it, how you're going to take it, and I will be informed by your wisdom. That is good medical practice. That's not what we do in trials. What we do in trials is we tell people, this trial requires that you take it every day. And then so they tell us they do. But in practice, we're seeing a high level of concordance between what people say about what they're using and what they're actually using. So incredible. We can believe our patients. Hooray. So this isn't, that data that I just showed you is from gay men in the United States. High levels of adherence are not just achievable by empowered gay men in the United States. We also see high levels of adherence in young heterosexual men and women in Botswana. In their demonstration project, we see 90 to 100% of men and women achieving very high levels of protective concentrations in the course of PrEP demonstration projects. So PrEP works if it's taken, and people can take it. So the next question is, does anyone want this? Is anyone going to use it? Can it be used on a wide enough scale to have an impact on the HIV epidemic? That is a problem of dissemination of PrEP innovations. And the news from San Francisco is yes. Albert Liu, my colleague at the San Francisco Department of Public Health, published in late 2013 evidence that PrEP was, as a concept, was being handed off from the innovators down here, the 2.5% of people who will try anything as long as it's new and it has some promise, that those innovators were starting to pass the PrEP concept off to early adopters, who are characterized by people who will use it, but only if they're sure that it really works and it really works well. So early adopters are very interested in knowing how well PrEP works. They care a lot about whether it's 99% effective or 100% effective. And there's endless debate online about whether PrEP is 99.5% protective or 99.8% protective. They care that it works. And we know that from marketing as well. I mean, if you're marketing iPhones to early adopters and there's one little feature buried 3 tiers below that doesn't work the way it should, you're going to hear about it. Because early adopters are characterized by people who really want it to work. And for PrEP, that means it has to work really well when used. And the good news is that it does. But toward the end of 2014, we were able to show that 10 to 15% of gay and bisexual men in San Francisco were already using PrEP. The early adopters had adopted. And they're starting to pass off the concept to the early majority. Now, the early majority is different. Early adopters don't need to see anyone else doing it. They just want to know for sure that it works. The early majority care about who else is using it. And I'm starting to see that in my clinical practice. People come in. Last year, they came in saying, I want PrEP because I heard that it really works well when used. This year, more and more, they're coming in saying, I want PrEP because everyone online's doing it. And I don't want to be left out. My impression is that many people in Australia are innovators at this point. And that may be the spirit of the place, or it may be the stage of the dissemination of innovation. People are interested in PrEP because it's new and exciting. For sure, PrEP rollout is happening in the United States. This is information from Gilead Sciences, which is required by our Food and Drug Administration, our regulatory authority, to do surveillance on how much PrEP is being used in the United States. Their information, based on pharmacy databases, is that PrEP use in the US over the last year increased 332%. What does that mean in terms of actual numbers? If there was 8,500 who we know from the databases were dispensed PrEP, and those databases only represent 39% of the prescriptions that are filled, we can calculate that something like 22,000 people are using PrEP in the United States by the end of the first quarter of 2015. Happy to say that about a quarter of them are in San Francisco, my hometown. But other cities are also seeing uptake in PrEP, particularly New York, Los Angeles, Seattle, Miami, Washington, D.C., Boston, Chicago. It's interesting to speculate about why demand for PrEP hit a tipping point. In San Francisco, we can see from this information from Kaiser that demand for PrEP here in the solid line stayed at a relatively low level for more than a year after it was approved by the Food and Drug Administration. And then subsequently, sometime in the third quarter of 2013, boom, there was this huge demand, and everyone could feel it. Our clinicians were saying, Suddenly, PrEP went from who cares, I don't even know what that is and don't care, to I want it and I want it now. And that all happened in the third quarter of 2013. We're all scratching our heads. What happened? What did we do? One thing I'm confident of is it was nothing that I did personally. I didn't publish any paper around that time. I didn't give any speech. It wasn't me. Sorry, Lavinia. But it wasn't me. But what was going on is that there were 2 demonstration projects going on in San Francisco, and it was building a word-of-mouth support for experience with PrEP. And US FDA approval, our regulatory authority, that came in 2012, and that was important. It gave PrEP a certain amount of credibility among medical providers in particular. But I think that it was really information that PrEP works really well when taken, that we published in September of 2012, and that publication really wasn't noticed. It was in a scientific journal named Science. But it was almost a year later when a blogger on PrEP Facts, a Facebook page, said, look, PrEP works 99% of the time if you take it daily. And that message went out to more than 4,000 members of his Facebook page called PrEP Facts. And Damon Jacobs is a true pioneer in community education, partly because he was the first PrEP user to go public by name. So the first PrEP user that I know of in the world who went public with his own name did so in September 2012, and he started the Facebook page because he realized that there was no real social support for PrEP users. And his name is Damon Jacobs. He's still very active. His PrEP Facts page now has 10,000 members. So kudos to him. And I think that it was really the word-of-mouth campaign, the social media that showed people how well it works when used that contributed to demand taking off. But we're going to talk more about stigma. The other thing that was going on during this period of time was a lot of stigma that finally reversed. But before I get to that, let me talk about who's using PrEP in the United States, or at least in San Francisco. These are the results from 3 different independent surveys. And the good news is that the 3 surveys varied dramatically in how hard they were to do, how expensive they were, how cumbersome, and yet they gave similar results. We have a walk-up survey done by Stop AIDS and the San Francisco AIDS Foundation. We have a very expensive probability survey done called the National Health and Behavior Survey. And we have a convenience sample of visitors to a municipal sexual health clinic called the San Francisco City Clinic. All 3 show that 10 to 15% of gay and bisexual men in San Francisco had used PrEP by the end of 2014. And more importantly, those who had the most to benefit from PrEP were the ones using it the most. Up to 63%, or 2/3 of men reporting 6 or more intercourse partners with whom they had not used a condom, 2/3 of them had already used PrEP by the end of 2014, whereas people reporting very consistent condom use were using PrEP only 3 to 8% of the time. And that, by the way, is the rate of sexually transmitted infections in that group. So even many of them had indications for PrEP. So PrEP is being used, we think, by about 5,000 people in San Francisco, and not just men who have sex with men. Women are using it to make conception safer with their HIV-positive partners. They're using it for safer conception as part of co-parenting agreements, and they're using it to diminish their risk associated with their sexual and injection drug-using contacts. So women use it too, and it's powerful for them. PrEP is controlled by bottoms. It's the first time that I know of that HIV risk is being controlled by the bottom. Previous to this, we've had to rely on the active partner to take medicines, to know their HIV status, to use a condom. The power of PrEP is that the receptive partner controls their HIV risk. We're going to get back to that as well. So in the scale-up of PrEP in San Francisco, we think we've come a long way. 10 to 15% of gay men are using it. We think our target level is about 30% of gay and bi men. And how do we know that? Well, if we get to about 30% of gay and bisexual men in San Francisco using it, and it continues to be the people who will benefit the most, that will satisfy their expressed demand that we can tell from survey. That will meet the need based on eligibility criteria published by our Centers for Disease Control, and that will be sufficient to reduce HIV transmission by 70 to 90%. So we've set these goals, they're ambitious. We're about 1/3 of the way there by the end of 2014. So let's get back to what happened to PrEP demand. Why did it stay flat for such a long period of time, and why did it reach a tipping point? A lot of it was stigma. And this was just one emblematic paper where David Duran wrote that the PrEP users were Truvada whores. And he talks in very stigmatizing language. He says, for legit couples who are in monogamous relationships, this might be something to consider. But for men who engage in unsafe sex and with other men, this is just an excuse to continue to be irresponsible. I mean, this is proper English. I'm sad to say that this kind of vitriol was being said in the bars, in the clubs, online, in blogs. I mean, there was a lot of vicious attacks, mainly gay men attacking other gay men. This went on, really, for a year. And it contributed to no PrEP user being willing to come out and say, I'm Bob Grant and I'm a PrEP user and I'm proud of that. No one was saying that. But I'm happy to say that it changed. This same author, David Duran, developed an evolved opinion on PrEP. And he writes almost a year later that he now believes that whether Truvada is being used by a monogamous couple or a single promiscuous person, a sex worker, or anyone who chooses to take the pill is doing the right thing for themselves. Only that person knows if they are putting themselves at risk, and potentially eliminating another infection is a good thing. And so why did David Duran change his mind? It's because people stood up to him. He's actually a compassionate fellow in the end. But Adam Zablosky, for example, said, you want to call me a Truvada whore? Call me a Truvada whore. But I know that I am proud to be taking care of myself. I'm taking care of myself. I'm taking care of my lovers. I'm taking care of my community. Call me what you like. I don't really care. And it was Adam and others standing up to the stigma and coming out as proud to be gay, proud to be on PrEP, proud to be taking responsibility that makes the stigma just disappear. You can't continue to throw mud on people who are trying to protect themselves. So I wanted to hear more. Let's see, there's maybe a slide. Oh, I wanted to present this slide because it's not just the common folk PrEP users. We've also heard from our elected officials. This man, Scott Wiener, is one of our most popular elected supervisors in San Francisco, and he came out as a PrEP user, writing in the Huffington Post, after consulting with my physician, I went on PrEP to further protect and take personal responsibility for my health. I'm HIV negative, and I want to remain that way. As an elected official, I have an obligation to do everything in my power to support those living with HIV, increase public awareness about effective HIV prevention, and reduce stigma and shame. So it's testimony like this that changes the discussion from Truvada whore to Truvada hero. So I wanted to give more first-person testimony, and we have it. Papers are in press from ethnographic research, but I chose to use to illustrate some first-person testimony from news articles just because you get to see their photo and it's more compelling. But everything in this news article, brilliant news article, in fact is supported by our ethnographic and anthropological research. Take the testimony, for example, of Mark Thompson, a 46-year-old, and this was quoted by Chris Godfrey, the journalist in The Independent, just last month. He says, I'm an HIV-positive man. Let me stand over here. I'm on treatment and I'm undetectable. So it's really unlikely that I'm going to pass HIV to my partner, but relationships can be a challenge, as HIV is a big barrier between me and the guys I date. Sometimes sex lacks intimacy, and you don't always get close to each other. There's always the fear in the back of your mind that HIV could be passed on. If we had PrEP, it would take the fear away. So this is what we're hearing, that PrEP is diminishing HIV stigma. It's diminishing the fear associated with being in love with an HIV-positive person and having sex with an HIV-positive person. And that is making the relationships between positive people and negative people more human, more connected, more safe, more healing. This is what makes HIV stigma disappear over time. Cal Stroud, a 23-year-old, quoted in the same article, said, PrEP would allow me to have sex without fear for the first time in my life. Imagine that, 23-year-old gay man. For the first time in his life is having sex without fear. It would remove the month-long hangover of psychological anguish after sex, worrying about whether or not I might have put myself at risk for HIV and looking for the slightest sign. The entire gay community is affected by this kind of anguish, and it only fuels the epidemic because When people feel anxious, they don't talk about it. So people have puzzled over why PrEP users often trend towards safer sexual practices. What is that about? Aren't you on PrEP because you can stop taking condoms and because you can have more sex partners? Well, sometimes that is the reason, and it's a valid reason. But oftentimes what happens when people are on PrEP is they become more mindful of their sexual goals and their practices, and they start thinking, what do I really want out of this? And what am I really afraid of? And as the anxiety dissipates, they start to get clarity on what their life goals and their sexual goals and their social goals should be. Nick Perry, 42-year-old, said, I don't need PrEP to stay alive. There's other things I can do to stop exposing myself to the same kind of risks. But the attraction of this is it makes something foolproof. It allows me to protect myself when I'm brushing my teeth and not whilst having sex. Frankly, I saw it as a way of making sex less awkward, because in the real world, even someone as relatively boring and sensible as me is liable to make an over-optimistic judgment about the other guy and his status. And so he's being realistic. He's saying, look, PrEP allows me to develop plans for my safety in calm moments. And in those calm moments, I can make effective plans. I can decide what do I really want, what I don't want, how am I going to get through this. Justin Harbottle, 33, says condoms are fantastic at stopping HIV, but only when you use them. And for some people, this can be really difficult. And I think in the PrEP era, we're hearing for the first time a robust discourse about what's so hard about condoms. But for him, he says, for one, you have to use them in the heat of the moment, which isn't a state of mind renowned for rational decision-making, especially if you're drunk or high. And even if you have made that choice, being assertive and able to negotiate it with a partner can be a big barrier. So one of the great things about PrEP is it allows you to take a rational health choice at a time that might be easier and without needing the partner's agreement. So power to the bottom, power for people to make plans and to develop an effective strategy for their health. So is PrEP having an impact on San Francisco? My colleagues from the Department of Public Health and the University of California and I presented this at the retrovirus meeting this last year. And yes, at the end of the day, this is published just last week, we see that HIV infections diagnosed have decreased by 30%, and that's in the red line, in the last 2 years as PrEP rollout has expanded. Now, is this only because of PrEP? Certainly not. We also have very effective treatment programs and testing programs. But a point that I think we have to acknowledge is that the main thing that changed in the last 2 years is we went from nearly 0 PrEP users to 10 to 15% of gay men using PrEP. That was the big change. Our treatment programs had been successful over the last 2 years. They didn't get much more successful. So this is largely PrEP, in my opinion. It's not entirely PrEP. It takes a village. It takes multiple concepts to end this epidemic. Our modeling predicted that the relationship between PrEP use and numbers of new infections would be as in the black line. We know in 2011 there was virtually no PrEP use in San Francisco. That's based on surveys. By 2014, about 5,000 people were using PrEP, representing about 4,000 years of PrEP use. And we predicted there would be about 300 infections that year. And sure enough, that's how many there were. So we predicted this, it happened. Doesn't mean the prediction's right, it just means we got lucky. And that something's going on here. So people will sometimes say PrEP versus treatment. You know, why are you promoting PrEP when not everyone's on treatment? And that's a valid concern. Let's face it, treatment is a real win. Treatment prolongs life. Treatment lowers infectiousness. Treatment helps people feel safe from HIV and AIDS disease. It has multiple benefits. And we're advancing treatment, but we've kind of gotten stuck, frankly, on HIV stigma. People sometimes hesitate to start treatment because they're afraid of the drugs, they're afraid of being identified as HIV positive, they're afraid of acknowledging their own HIV status. And so there's several ways that PrEP actually enhances treatment programs, and we're seeing this. First of all, it gives us less HIV infections. To the extent that it prevents infection, it prevents the need for lifelong therapy. People, because of PrEP, can see in their real life, in first-person testimony, they can see that the medications that we use for HIV are safe. And this is a very valuable message. We can publish hundreds of papers in the medical literature about how safe the new generation of medications are, but it's powerful when you hear someone who's HIV infected sign up and take the drugs. And my anecdote for that is a Chicago woman, 22-year-old, had an HIV-positive boyfriend who she loved and wanted to stay with. The boyfriend would not start therapy. He said, I'm afraid of judgment, I'm afraid people will find out I'm HIV infection, and those drugs are poison. But this girl wanted to stay with him. She loved him. She was even thinking about maybe having a baby with him. So she came in and she asked for PrEP. And of course she got it, no question, because she was asking to protect herself when her boyfriend would not. The amazing thing is a month later, the boyfriend shows up in clinic and says, start me on treatment. Start me on treatment. I thought the drugs were poison. My girlfriend's on them. There's nothing bad happening to her. I was afraid of people judging me. She stood up to that judgment and said, I'm protecting myself. He stepped up and he treated his own infection based on her leadership and her power. So this is one way that PrEP empowers treatment. Antiretrovirals are no longer associated with HIV. It helps destigmatize the medications and HIV. It motivates HIV testing and earlier diagnosis. It builds broader constituencies for procurement and HIV programs, and this is key. In the treatment era, I think that people fundamentally believe that HIV is a problem for people living with HIV. And you can have some charitable intent toward people living with HIV. You can have some compassion for people living with HIV. But in the end, the attitude was that it's their problem, not mine, if I'm HIV negative. PrEP changes all that. HIV becomes our problem. And we can see more clearly than ever that the fear of HIV affects us all. It undermines our ability to seek human connection and sexual exploration and to build our social lives. So HIV hurts us even if we're not living with HIV directly. We all live with HIV. We're all limited by HIV. And so people get that in the PrEP era because they're able to take action and be part of the solution, part of the end of HIV and AIDS. In addition, PrEP distributes responsibility for prevention, which undermines HIV stigma, undermines criminalization, and engages and empowers seronegative people. Finally, we're seeing that PrEP fosters agency. And no one said it better than a sex worker from Zimbabwe, Batambili, at the tender age of 23, told the World Health Organization in Geneva, it empowers me, PrEP empowers me. And she said, I now can dream and envision a long life and a long career, something that she never had done before. She assumed that she would get HIV, it would go untreated, and she would die of AIDS. In the era of PrEP, she can imagine living a full and long life. It empowers her, and it's not just for gay and MSM. So in conclusion, PrEP is safe, effective, and underutilized. Adherence to daily oral PrEP is feasible. Scale-up has occurred in San Francisco and contributed to the decline in HIV infections. PrEP uptake is higher during periods of risk. There are multiple fringe benefits of PrEP, including empowerment, healing of prior trauma with fear, broader support for ending HIV transmission. So I just wanted to end with a comment about stigma and words, because this is something that we all can do today to help end HIV epidemic and stigma. And I want to be picky about words. And I want to be picky about words because I care about words, but also because Nelson Mandela at the AIDS conference in 2000 told us to care about words. He said, it is never my custom to use words lightly. If 27 years in prison have done anything to us, it was to use the silence of solitude to make us understand how precious words are and how real speech is in its impact on the way people live or die. This is the former president of South Africa. So, do we need a new sexual health lexicon? Let's reflect a bit on the words that we use in the HIV field, whether it's public health or medicine or journalism. And I would submit that we often use stigmatizing words. And why do I say this? I say it because all of the words on the left-hand side here invoke an us and a them. An us that's responsible and generous and caring and loving, and a them who's irresponsible and needy and dangerous. So the us versus them is at the heart of stigma. It's exclusionary. And even if we exclude with charitable intent, even if we exclude and create this division between us and them for the purposes of us helping them, it's still stigma. And so we use words like them, their needs, high-risk people, risk behavior, targeting them for programs, discordant couples, and adherence. All of them imply there's an us and a them. We don't have to use these words. We can use inclusive words. So we can imagine talking about us instead of them. We can talk about our desires. Instead of high-risk people, we can talk about popular and affectionate people. Instead of risk behavior, let's talk about intimate sex. And instead of targeting, we can mobilize. And instead of discordant couples, we can talk about people who are in love. And they're willing to stick it out. And PrEP use is a much better term than adherence, because adherence highlights the one pill you missed last week, and it fails to celebrate the 6 pills you did take. So I think we should celebrate the pills people do take, not the ones they miss, not punish the ones who miss. So PrEP was made possible by mostly young study participants who believe that research could improve their lives. I'm here to try to make good on that promise. So thank you very much for your attention.
We're doing questions later, so
Okay.
Fantastic. Thank you so much, Bob. And you can see why we brought him out to Australia. And he's been doing this fantastic, I think, job of talking in very pragmatic and real-life ways to policymakers and decision-makers all over Australia about PrEP. We're going to save questions for Bob later, but someone did text me, that wasn't on the screen, I'm sorry, and asked whether or not Bob was on the take from Gilead. And he's not. I'm just letting you know now. He normally does the big long list of exclusions and acknowledgements and things, and just letting you know, he does not receive money from Gilead for this. Gilead's the drug company that makes Truvada for PrEP. Just sorry about that. Next, I'd just like you to welcome Dr. Irina Zablotska-Manos from the Kirby Institute. We have 300 guys currently enrolled in a PrEP trial in New South Wales. It's involved a lot of community support and clinician support as well as research support over the last little while. So Irina's going to give you a very brief overview of the trial. She is an epidemiologist and senior research fellow with the HIV Epidemiology and Prevention Program. Trying to do that fast, it's hard. Working in the field of HIV behavioural and biomedical prevention. And she leads the trial with Andrew Grulich and others at the Kirby. And I'd like you to make her welcome.
Thank you very much, everyone. It is a pleasure to be here and to have a possibility to talk about the study of our own study of pre-exposure prophylaxis here in New South Wales. Let me say to start that I've been working in the field of HIV prevention here in Sydney for about 10 years. The first 4 of them working on managing our gay community periodic surveys. Through that time working on the surveys, I've realized how great community we have here in Sydney, how engaged people are with research, with HIV prevention, how engaged our community is in caring about each other and contributing to research to have something back to the community through the research, through the evidence that we collectively provide and collect. When the first data about the effectiveness of pre-exposure prophylaxis came out, thanks Bob and his team for great work and providing that evidence for us, we realized San Francisco has a demonstration project, has a few of them. People in San Francisco can benefit from PrEP. We are so similar, we have so many similar features, why don't we have a project? So we lobbied Gilead for having our own, and we were successful with that. We have received support from the company in terms of the medication for about 300 participants to provide access to PrEP. We have received support from our New South Wales Department of Health to manage the project. And here we are, we have our own PrEP demonstration projects here in New South Wales. It started in November last year. At the time when we were building the study, we were thinking, well, will we be able to recruit as many men in the study? We have been using approaches through recruiting through clinics, recruiting through other previous studies that we have conducted in the community. We were wondering whether we can achieve can recruit so many people in the study quickly. And guess what? We had so much interest in the community. We had so much interest in participation in the study. We had so much interest in starting taking PrEP that we enrolled the desired number of people in the study very quickly. And unfortunately, we were not able to provide access to PrEP to everyone who in the community who would want to go on PrEP. And it turns out now that there are so many more people that would like to go on PrEP than we originally predicted. Now, the study is designed for 300 people. It receives support from Gilead and New South Wales Health, as already mentioned. It is designed to set up and evaluate a system of delivering PrEP through our health services. The study is focused on assessing how PrEP works. Is it as effective as in other studies overseas? Are people using and will people be using it as it is recommended, and it is recommended daily? What would be the best ways people would want to use PrEP, and how PrEP may have effect on other aspects of life? The study also has contributed from the very beginning to the development of our New South Wales and national guideline on how clinicians would prescribe PrEP, identify people who would be most eligible for PrEP, and prescribe PrEP and follow people on PrEP. From the very early days of the study, it has contributed already back to the community. The data that we are collecting so far, and some of you are helping us to collect, will be able to improve health services in terms of provision of PrEP to people who need these. We have reached about half of our participants, about 6 months of follow-up on PrEP. We will soon be analyzing data in detail and providing some feedback back to the participants and back to the community on how PrEP is being used here and what impact it has. We have already started looking at how people are using PrEP and what impact it has. And let me share a little bit with you. We asked participants for how long would you like to take PrEP and whether you are able to take it on a daily basis. And guess what? Almost 100% of people said we would love to take it for at least 12 months, and we are confident we can take PrEP daily. We are looking at the data now, and we see that actually almost everyone is taking PrEP as recommended, with people missing accidentally very small number of pills, which are consistent with the highest levels of protection as were described by Bob in talk earlier today. We designed the study in such a way that we would target people who would be at highest need for pre-exposure prophylaxis. That is, people who probably have the highest risk, and they assess that they are at highest risk for HIV infection. We haven't seen any HIV infections in the study so far. Although we probably would predict to have a few infections by this time in the group of people at high risk for infection. That means that PrEP works. It works in our context. People can take it daily. People can maintain very high, consistent use, and it does work when people are motivated to take it. This is a great news. It means that there is a good word to pass on to those who haven't decided yet whether they would want to go on PrEP or not. So sharing those experiences of consistent use would be really great in the community. We will be, as I mentioned, we will be analyzing data in more detail, and as we reach about 12 months of follow-up, this will be enough data to analyze and share back with the participants of the study and the community in large. So please stay tuned on the website of the study for the announcements, and we will see each other once again with some more results about what the study shows. As a last word, I want to say that at the time when the first evidence of pre-exposure prophylaxis came out, we had a good reason to stay optimistic. Now we have many good reasons to stay optimistic. If we can use this great tool for HIV prevention the way how it is designed, we hope that this prevention tool can actually make change in the life of our community. It may change the life of each one of us if we can use pre-exposure prophylaxis and use it as it is designed. So let's make it available for the community broader than the 300 sample that we have. This is what we are working on now. We are trying to extend and expand access to PrEP, and hopefully we'll have a good news for the community soon. So once again, stay tuned to the results of the study and to the new developments in the extension and expansion of access to PrEP here locally. Thank you very much, and thank you to our speaker also, Bob Grant, who brought great news about pre-exposure prophylaxis in the first place, and now brought us great summary of the evidence from the studies conducted in the US and internationally that enlightened us to hope. Thank you very much.
Thank you very much, Irina. We do live in interesting times indeed, exciting times. So look, let me just invite the panellists up now to the seats in front. First of all, and I'll introduce them as they move. So Lavinia Crooks is the CEO of Ashram, has been since 1999. She's had significant involvement in HIV over many, many years. In fact, she's been made a member of the Order of Australia for her contributions to HIV policy work over time. She represents Ashram at the federal level. She's been involved in national strategy writing and is just generally a bit of a legend. Lavinia. Chris Williams. Chris is a HIV negative gay man, originally from the UK, been living in Melbourne for a while, sad, sorry about that. When he first heard about PrEP, he saw an opportunity for change, got excited, started a Facebook group, and is all about reducing anxiety about contracting HIV through sex and spreading equality and reducing prejudice and discrimination. Chris Williams. The lovely Dr. Tim Barnes. Tim Barnes joined Holdsworth House after 8 years at the Albion Centre. Tim worked prior to that for many years in general practice in Sydney, following his residency at Sydney Hospital. He is particularly interested in HIV and sexual health medicine, public health, skin conditions and men's health more broadly amongst general medicine. Tim. The fabulous James Gray, who works at ACON, sorry, biased. He's currently standing in for Nick, who had emergency dental surgery this afternoon. So Nick Parkhill sends his apologies. But he's replaced by James, which I think is not a bad thing. And he is currently the manager of gay men's sexual health programs at ACON. He oversees a range of programs covering HIV health promotion, prevention and community-based testing, the A-Test services, which you've probably already heard about. And he's been working in the HIV sector since 2007, has had international postings in Thailand and has gone to the UN a couple of times as well. So he's doing all right. Please welcome James. And I'll ask Bob to wander up there as well at some point. But Lavinia, I'm going to kick off with you, and I'm going to ask each of the panellists to give a very brief, because I know we need to get on to questions, brief statement. Lavinia, I'd like you to, if you could talk from Ashram's perspective about some of the current context for PrEP in Australia, and in particular why it's not just on the shelves of your local chemist. If you could talk us through that, thanks.
Yeah, thanks, Karen. Look, I think one of the things that's been really confusing with PrEP is a suggestion that it's somehow the government that is holding back on making it available, when in fact it's the government process as far as the way our drugs are licensed. And Truvada is licensed in Australia for use as a treatment. So for the in order to meet that condition, one must have HIV. It's not licensed for use as a preventative. And so that's been the issue, unlike in the States where the FDA actually went out and to some extent sought Gilead's submission for a change of purpose. Australia can't do that, and that is in itself a retrograde step, and that doesn't mean it's not something we should try and change, but it is the way the system currently is, and there's a review of the TGA at the moment, and that's one of the submissions that many of our agencies have put in for. So it's not correct to say there's a health minister in this state or federally who's sitting on it or anybody's not moving forward. There's an application, it's a horribly slow process, it is going through. We anticipate getting some feedback out from the November-December meeting of the TGA, and then that will facilitate an application to the Pharmaceutical Benefits Advisory Committee, which is the one that considers whether or not a drug will be subsidised. So it's a two-stage process. I think we should take it as read that the TGA, the Therapeutic Goods Administration, will licence it for prevention. I don't think there's any dispute with that. And I've said that publicly on a number of occasions. Whether it will get subsidised is, I think, where we're going to come up against a bit of a battle. And it's going to be a battle around how tightly do you restrict risk and how broadly do you provide access. And it will, if you only treated 50 people and you treated the 50 people who most needed it, then it would be cost effective for that 50 people, clearly. But it's not going to have much of a community impact, and it's how long do we stretch that? And that's not something that's not a cost effectiveness analysis that our regulators and the people who are charged with testing the models are familiar with working with. It's not something that the sector is that familiar with, and I mean the health regulatory sector is that familiar with. But I think that's where advocacy comes in, and even though they would say advocacy should not play a role, it should be based on science. It's a matter of pushing that science and making people truly understand that science. There would be nobody who would dispute the benefits of providing Truvada or any PrEP to a woman who's giving birth, who hasn't previously had treatment. There are, scientific givens that we need to be putting out there in the face of opposition. And realistically, if we were talking about a drug that was $1 a day, we wouldn't be having this debate. It would be being rolled out quickly, and gay men who were not on it would be being told they were being irresponsible.
Mm. Okay, thank you, Lavinia. James, I just want you to outline very briefly the drug is not widely available unless you're on a research trial. You can't get it unless you are importing it yourself. And I'll ask Tim to talk a little bit about that in a minute. It's difficult to get. So, James, what are some of the things that ACON is currently doing to inform and educate and make information available to gay men in New South Wales?
Sure. Good evening, everyone. As Karen pointed out earlier, ACON's taken a fairly firm position that PrEP is a really important addition to the suite of prevention technologies that we should have available in New South Wales and Australia more broadly. So ACON's been started talking about PrEP more formally at the start of this year. We have been sharing some information, but all the pamphlets that you can see on your chairs, we developed those with assistance from other people in the sector and started distributing those at the start of this year. Initially just online, particularly through Ending HIV and our Facebook group through that platform. And we've now also started distributing hard copies both to gay venues, sex on premises venues, anywhere we think that people might see them. And there is a lot of interest in PrEP. We're getting daily questions through our testing services. We're getting lots of requests for information through just people calling up or sending us emails as well. So there is a clear community desire for PrEP and for PrEP access. And we're going as far as we can within, unfortunately, some tough regulatory frameworks about how much we can say on PrEP, given that it hasn't been licensed. We're going as far as we can, and we're going to keep pushing that as much as we can.
Fantastic. Talking about community word of mouth, I'll bring Chris in a minute, but Tim, are you able to let us know how a person walking into your surgery, what that conversation's like when they want PrEP? How do you help them with that?
Yeah, thanks, Karen. Look, it's a conversation that we're all having more and more, particularly in the last couple of months. I think that the community is more aware of it. I think the doctors are more aware of it, and there's been sort of a sanction about its use, although it's off licence, as it is with PEP. We've been quite happy for years doing PEP. I think with the guidelines that came out earlier in the year, it was basically saying, if you're going to do it, this is how you do it. I think there's information that the patients get and the community get, and we can also pass that on if they haven't received it, and it supports a way, sort of being a process of getting the medications. It's fairly onerous at the moment unless people have got enough money to walk into the hospital pharmacy and fork out $700 or $800 for a month's worth of Truvada. But we've been getting patients ordering medications online for many years, particularly when I worked at the Albion Centre, there were a lot of patients who were Medicare ineligible, and for years they imported their medication, and we know they're fairly good, reliable sources for online. The concern's always, of course, that your Visa card details go out one end and nothing comes in the other end. But to date, we've had very good supply chain for ordering the generic Truvada. And at Holdsworth, we've probably got between 50 and 70 people privately importing. And I'm not aware of any people who've had a problem either with the medications turning up or with them being held, because it's actually quite legal for individuals to import the medications for their personal use, albeit off licence. And a script can be obtained. I think it's a very good chance for the patients and the doctors to get down and talk about what they're actually doing sexually. It's a really good springboard into talking about sexual health checks and other things that maybe have been swept aside a bit when it was just an HIV test, whether you're positive or whether you're negative. I think we're engaging people better about other sexual health considerations. I think that my experience with both the Prelude trial and private importing is that people have been able to take the medications. As Bob said, it's not difficult. People seem motivated. People have been happy to import for their own use and engage in monitoring to see the effectiveness, and also to gauge if there is any adverse effects from the medications, which are something we know very much about, what to watch for, because the meds have been around for many years, and the majority of patients who are treating their HIV are taking Truvada. So obtaining it is not that difficult. You just need to engage with somebody who's not going to just write your script. It's a matter of engaging in just talking about sex, how it's different, why you want to take it, why you might not want to take it, what your concerns are if you think it's the wrong thing to do, and why somebody wouldn't want to protect themselves and possibly remove some of the fear that they've lived with for many years because they're worried about catching HIV, regardless of whether their partner may be on treatment and supposedly undetectable, or the person they got off with at Bodyline might have said they're on treatment and undetectable. I think it's like having your seatbelt and your airbags. You can never have too much protection.
Thanks for that. So Chris, can you briefly describe your decision to take PrEP? Also, and I think I heard you speak in Brisbane last week, and if you could just talk about that organisational process and what you do to actually maintain your supply.
Sure, absolutely. So I've been taking PrEP since February this year, so it's about 7 months I've been on it now. I've been aware of PrEP for about 14 months, following some discussions with my housemate, who is the other administrator for the PrEP for Change Facebook group. He came back from a holiday in the States and had spoken to some Americans that are on PrEP at the moment. Came back and told me all about this incredible new pill that means that you can take it once a day and not contract HIV. So naturally we were very, very interested in what that meant. He hounded the Alfred Clinic down in Victoria to be able to work out when was it going to be available in Australia. As a result of that, the clinical trials, the Vic PrEP study down in Victoria started very, very soon after that. And I was still wrapping my head around what PrEP was at the time and what it would mean to be on PrEP. So I sat tight and I missed the boat on the clinical study. After a few months in, when I realised what it was, I went and hounded my GP and said, I want in. How do I get this privately? There's no room on the study anymore, so how do I get it? As a result of that and other requests from community members, he decided to go and write some protocols to publish for his practice, and he now prescribes PrEP down at one of the major clinics in Melbourne. The process is very, very simple. I go to see my GP, and he writes me a script for PrEP after doing all my tests, so I get full HIV tests, full STI screening, etc. When my test results came back negative, he said, fantastic, you're eligible for PrEP, put me straight on it, so I then have to take my prescription and order it online from an online pharmacy. It takes about 3 weeks, is my experience so far, to ship from an overseas distributor. It arrives on my doorstep, and then it's as simple as remembering to take it once a day. And fortunately, considering my driver to take it is to not contract HIV, when I wake up in the morning, that is a real strong driver for me to remember to take my medication. So for me, it's been really easy to remember to use PrEP every day. It's just there next to my multivitamin. I'm better at taking my PrEP than I am my asthma medication, which I've been on for 30 odd years. So it's actually not hard for me, based on my routine, to remember to take it. And it's, as a process of taking it, in terms of side effects, etc., my own experience was really smooth and really straightforward. Some people experience a bit of a stomach upset in the first week or so. I had a bit of a dodgy tummy for maybe 2-3 days. I was also in Singapore eating a lot of spicy food. But besides that, plain sailing. Some people report these incredibly trippy dreams for about maybe 10 days, about 10 days in. They subside, they're good fun while they last. And that's pretty much it in terms of what I notice. So I just take this pill, and fear, anxiety, any kind of thoughts around having to decide how I'm going to interact with somebody based upon maybe knowing their HIV status, it's no longer a factor in my decision-making process. Somebody else's status is no longer something that comes into any deciding factor of how I'm going to interact with that person.
Fantastic. Thanks, Chris. All right, I'm going to throw a question to Bob that has come through on the iPad, so it works, people. And while I'm doing that, I'm going to go a one-for-one. So there are 2 guys walking around with a roving mic, the lovely Gav and the lovely Di. They'll go down the aisles. If the person in the middle of the floor wants to ask a question, there might be a process of passing the microphone, but you guys will work it out. First question from the floor. Bob, can you comment on rates of condom use and also STI and Hep C incidents in PrEP users in San Francisco?
Condom use has been on the wane since the mid-1990s. And generation after generation of strategy for containing the HIV epidemic have really left transmission for STIs a chance to increase. And it really started with antiretroviral therapy, which we know effectively renders people less infectious, but it also does nothing to prevent transmission of syphilis, gonorrhea, and chlamydia. We had another strategy called serosorting or seroadaptive behavior, where people would negotiate with a partner based on their serostatus, HIV serostatus, never syphilis serostatus or gonorrhea status or something like that. And then PrEP is just the latest way that we're containing HIV, but sort of allowing STIs to spread. So I think that, in fact, in the end, STI, syphilis and gonorrhea rates are increasing in San Francisco. They've been doing it since the 90s. It's really the end product of a variety of all those strategies. I think that we're starting to realize that a better approach to sexually transmitted infections is to separate them from HIV. What we're finding is that PrEP users are really adverse to getting syphilis and gonorrhea, and they're thinking about that as a risk for the first time. And yet our messaging is often, don't get syphilis because it'll enhance your chance of getting HIV. Well, PrEP users say, I don't want syphilis because I don't want syphilis. And so they're talking to their partners about when they last got tested with syphilis, and I think that we're ready now for a public health campaign that's really focused on STIs and doesn't try to link it in some indirect way to HIV. I think that will help. In the end, though, some of what goes on during PrEP use is you get increased diagnostic rates. And if you look at the trends in San Francisco, it's in latent syphilis and rectal gonorrhea that's asymptomatic. And we have not seen an increase in primary syphilis or secondary syphilis, or in proctitis, which is a sign of long-standing gonorrhea infection of the rectum. And so our public health surveillance team actually thinks that what's going on with the current trends is that we're diagnosing more STIs, and that it's not, and that there may be a small increase in the rate of transmission, but it's mainly we're just diagnosing better. And why? It's because people who are in care for PrEP or treatment are getting tested for STIs.
Fantastic. Thanks, Bob. Yep.
Okay, awesome talk. Thank you everyone for coming. When we normally treat HIV infection, we combine Truvada with something else like a protease inhibitor, something like that, to reduce your risk of resistance. Is there any sort of risk that's been documented of Truvada-resistant HIV in people who maybe have a low adherence rate for the medication?
Well, is that a question for me, I guess?
Yeah.
It turns out the risk of drug resistance associated with PrEP was very, very low. And the only time that we're really seeing it is when people are already HIV infected when they start PrEP. And so we do recommend that people starting PrEP use the most sensitive test that they can get access to try to detect any sort of HIV infection, whether it's long-standing or acute infection that may be difficult to detect using a standard antibody test. So the risk of drug resistance is really limited to people who are starting PrEP who are already infected. So getting an HIV test before starting or restarting PrEP is really important. And so we encourage the use of rapid tests just to make them more available. You get the result the same day. The WHO is recommending self-testing worldwide at this point because it makes testing more convenient and easier for people. I think that we need to make testing really easy so that people can test or retest before starting or restarting PrEP. That's the main area of risk. But you know, on balance, preventing HIV infection is the best way to prevent resistance. And when we look at the risk-benefit, we have to consider, do I give PrEP and prevent HIV, or do I withhold PrEP because I'm afraid of drug resistance? And withholding PrEP because you're afraid of drug resistance is really a self-defeating proposition. Why? Because the infections that occur because you withheld PrEP all need lifelong treatment, and treatment is the main driver of drug resistance. And so what I tell clinicians is that if for some reason your main concern in life is to prevent drug resistance, and I don't recommend this as a focal point for your practice, but if that for some reason is the focal point of your practice, then you should be a PrEP advocate, because you're preventing HIV infections, which if you have to treat, you're going to generate resistance with that.
Okay, thank you very much. I'm going to take another question from the iPad while a hand shoots up and catches my attention. I'll direct this one to Tim. Dr. Barnes, can you tell us what routine scans, tests, other sort of monitoring you engage with for people that are taking PrEP in your practice, so kidney functions, bone density, etc.?
Yeah, I think the testing is fairly well based on long-term treatment of patients with HIV infection who've been on the same medications. The side effect risk is probably less in patients who are negative taking Truvada for PrEP than it is for long-term experienced patients who are more likely to have adverse effects from it. But certainly monitoring the HIV antibody test to make sure that while on PrEP that the person hasn't seroconverted, which shouldn't happen if they're taking it. Doing routine STI screens, because hopefully they're taking PrEP because they're having sex. We're always more concerned when patients come in and they're not having sex. And so if they're having sex, normal STI screens, and that whether it's arbitrary, whether that's 3 monthly, 4 monthly, 2.5 monthly, it's not written in stone, but around that sort of frequency. As far as, okay, what's the downside of taking medications? These medications are well tolerated, but there are potential side effects, and we're fairly familiar with them. And certainly monitoring kidney function, because the tenofovir component in the Truvada, it's something that can be affected by the medication, but it's easy to monitor. We don't have to give the patients injections or stick needles in their bones or do things like that. There's a fairly easy way of monitoring with the routine blood testing in terms of kidney function and a midstream urine test, which if you're doing a pee in a pot for the first catch for the chlamydia and gono, it's not hard unless you haven't had anything to drink to do a bit more in another pot to see how the kidneys are. And I don't think the patients find it too onerous. And it's just reassurance that they are protecting themselves but not causing harm along their way.
Sorry, if I can just quickly comment on that. In a lot of the work we've been doing talking around PrEP, we've been very, very clear that we refer people to clinicians with experience in HIV because they understand the types of tests that are required. And unfortunately, we are getting some inquiries where some people have just gone to a doctor who's never had anything to do with HIV before and they've just gotten a script and away they go. That is concerning, and that's why as great as it is that we have the option of importing and access through that, it really is a stopgap measure, and we do need better structures around rolling out PrEP formally in Australia because we need people to be linked into appropriate care.
Thank you. Andrew.
Yeah, thanks, guys. I've got two questions, if that's allowed. First is, how long does one need to be on PrEP in order for it to be effective? And then secondly, I mean, I'm hearing that it's probably not, that it's certainly advisable to get a script before you import it, but is it actually required? If you're going online, are there checks that you actually have a script, or can you just get it?
There used to be companies where they didn't require a prescription, but certainly the major importers now like a script, and they need that to be scanned and sent to them. It's also, in the rare chance that it were held by customs, just purely because it's a bottle of pills, to have it released to the person, they need a script because it's a prescription medication, and you really legally need that to have it released to you. It's very unlikely that it would be held by customs, and then it's only just to have a script to verify that the person's entitled to get the medication.
So, Bob, can you answer the other one, the other side of that?
So the answer to your question really comes from the clinical trial IPRGay and a series of pharmacological models that have been developed based on, so let's just say that there's, that my response is somewhat speculative, but this is our best guess as to the answer to your question of how many tablets. The first tablet gives a gay man 44 or approximately 50% protection. It's something. It's not what most people want. The second pill gets them to about 80 to 90% protection. The third, fourth, and fifth pill gets them from 80% to nearly 100% protection. So what I tell my clients, my patients, is that that they should try to get 5 pills in before they feel that they're at the very highest level of protection. But if they can only get,
You could.
but if they could only, in what? in their mouth? Yeah. We do know that tenofovir can be taken twice a day safely. Taking more tablets per day has not been tested. So if people want to be on an accelerated program, which I don't recommend, they could consider, say, for a weekend party, starting on Wednesday with 2 tablets, Thursday 2 tablets, Friday 2 tablets, and then they're off to the races. and then go back to once a day through the fun and games, and then the question becomes, how long after do they have to continue taking it? And there we know from the modeling that people will have protective levels for about 7 days after they've taken these loading doses, and so maybe for 7 days after the party. Now, I hasten to add that everything I just said applies for anal and rectal exposure. If the exposure is vaginal, we think that up to 20 tablets are needed before the highest level of protection is achieved. And that's because the medication takes longer to get through the intestine, into the blood, and into the vaginal tissue. So this is an important message for women and for trans men to hear, that vaginal protection requires up to 20 doses, not the 5 doses that we're recommending for rectal exposure.
Excellent, thank you for that.
Karen, can
Sorry,
I
sure.
quickly add to the import question earlier as well, just so that people are aware, it's something we talk about on the group a fair bit. In terms of getting medication into Australia, the TGA does have a personal importation scheme. So you are legally entitled to import up to 3 months of supply of Truvada, or generic branded Truvada, for your own personal use. So as long as the shipment is no more than 3 months worth supply, then you can do that and it should go through customs without question. So far, we've had no reports of anybody actually being stuck with getting their medication into the country. It's just making sure that you time your ordering online so that you maintain a regular supply so that you never run out.
Thank you, Chris. Great. Lavinia, I'm going to ask you a question and then you can make your statement as well. It's a win-win. So I've got a couple of questions and I'm going to mash them up together with basically a question around how interested you think the workforce are around the HIV prescribers, doctors, specialists in relation to PrEP. Are there waiting lists, those sorts of things?
From my experience, there's a lot of interest. The interest is growing and it's been growing steadily. And that's amongst what I'd call HIV doctors. So they might be prescribers, they might be people who work in sexual health, they might be people who are in some of the larger practices that have got, they may not be a HIV prescriber, but they're in that space. And they're the main people that we have to do with. And also from other doctors who are coming along to training. So they may not be wanting to be prescribers, but they're wanting to skill up on this area. And I think all of those people are able to manage what we're talking about with PrEP, particularly given the monitoring that's required both before a person starts PrEP, and I think the most important thing is to make sure the person is negative and isn't seroconverting. And that's something that, it's pretty easy to teach somebody to do. And as Tim said, the monitoring is very routine as well. So there is a level of interest that's out there. When a few months ago now, Mark Block and I surveyed what we call the HIV doctors nationally, asking them some questions about PrEP because we were starting a series of discussions and I wanted to be able to have a bit more data than just I reckon. But our reckoning was pretty good. We had two doctors come back saying they weren't interested in doing it, and that was because they worked, this is in the New South Wales sample, they worked in hospital settings purely in an environment where they were consultants with people who were infected, so they didn't come into contact with non-infected people. Everybody else was interested in finding out more, wanted more information, would do it. Some people wrote a book back to us and really went into a lot of detail, and that was great. And I think that's indicative of the amount of support there is for this. And it seems to me to be fairly rapidly growing support. I think we had concerns early on. I think people had concerns early on, particularly concerns about the development of resistance, people not taking pills. But we consistently see from all of the studies that are happening that that's not the case, and it's not causing the same level of, those things that were the potential alarms are being turned off, and that's being immediately reflected then in the clinician's preparedness to be more supportive. And I'm sure there'll be someone who says, my doctor wasn't, but we can't cover everybody.
Okay, well look, I think I'm conscious of time, we've got about probably 2 more questions left in us. So shoot your hand up anytime you want. Robert.
Oh, thanks, Karen, that's good. I've got 2 questions. I won't write a book this time, Lavinia. Peter, is it, from ACON? James, sorry, excuse me. About you recommend AIDS drugs online on your website and on this pamphlet. At Taylor Square Clinic, we've had a few patients come in recently saying they've found cheaper websites, $50 a month, where they don't need a prescription, and some are in China, I think, and others are in India. I assume they're not WHO certified. Should we have apprehension about the quality of the drug? And also, if they don't need a script, they might not be getting monitored with any frequency.
Yeah, absolutely. That's definitely an issue. So we've also heard about some of these cheaper ones. There's another one, I think it's All Day Chemist, I believe it's called, and I know someone down in Victoria has actually ordered some to test the drug and actually check its quality. So that's the sort of thing we want to wait before promoting any other avenues. to ensure that people are actually getting what they're asking for, because it would be a disaster if someone went and said, I'm on PrEP, and they start seroconverting just because there wasn't any active ingredient. So, online ordering in general for so many different things, you have to be really, really careful. So we're being reasonably cautious around who we recommend people go to. But the fact that there are some cheaper ones is absolutely going to get people's attention, because AIDS drugs online, it's something like $100 a month. That's a lot of money for a lot of people, and that takes it out of the reach of a significant portion of our community. And we can't have a situation where PrEP is only available for gay men who can afford it, rather than for gay men who need it.
Thanks. And my second question is to Dr. Grant. Thanks for a great presentation. And I recall last year at World AIDS, a talk also called A Tale of Two Cities was comparing London and San Francisco and why the experiences were so different. And it seemed that it had a lot to do with area, that when they said London, they meant Greater London, and San Francisco meant a smaller defined area. So Sydney is a very urban, spread out place with gay men and other people at risk spread all over. So I wondered, the great results you've had in central San Francisco, has there been a ripple effect to greater San Francisco, poorer, blacker, Latino, industrialized suburbs? Are you noticing any benefit in those places?
I think it's too early to be sure. We do know that a number of people from the broader San Francisco area come to San Francisco for PrEP services and for treatment services. So, for example, at our magnet clinic at the San Francisco AIDS Foundation, a large portion of our people actually migrate in from the outlying areas to get services in San Francisco. Why? Because it's fun to come to San Francisco, and because I think our services are culturally competent. I mean, we really try hard to welcome gay and bisexual men and their sexual and social goals. And so, I think it's too early to be sure about the outlying areas. I will say that in the latest surveillance report, they did stratify the analysis based on residents in San Francisco versus residents outside of San Francisco, and there was a trend toward decreasing infection rates in both groups.
Okay, thank you. I've got another question quickly. Bob, in relation to injecting drug use and HIV risk through that route, is PrEP as effective in that context as is in others?
We don't know, really, because the only study that was done primarily in injecting drug users did not provide the standard of care, which is free access to clean needles for everyone in the study. And so we really can't be sure. We do know that the mainstay of prevention in injection drug users should be access to clean injection materials and, I think, safe injection facilities. I mean, that is the state of the art. We know that clean needles prevent not just HIV, but prevent hepatitis C infection, which is a significant concern. Now, as for whether PrEP is effective, I can't say for sure. We do know that post-exposure prophylaxis is effective after needle stick injury, and that was studies based primarily in healthcare workers. And I would extrapolate from that the concept of the concept of chemoprophylaxis, whether pre or post-exposure, probably works for parental transmission. But in practical terms, it doesn't really matter, because we know that injection drug users prefer access to clean needles as their preferred prevention strategy, and it is in fact their preferred prevention strategy because it's the best way to prevent HIV. It prevents so many other things as well.
Absolutely. One more.
Thank you. Thank you very much. I'm here. Thank you very much for the presentation. That was incredible. The question I have is around recreational drug use. A lot of gay men, not a lot, some of us, use recreational drugs at different times. Some people use more regularly. There is the MTV generation at the moment. People talk about meth, Truvada, and Viagra on one night. Some people take more than that in one night. There's often sleeping pills or amyl or other drugs involved in one night. Is there a study around Truvada and the interaction with all of these recreational drugs? And the second part of that question is, what do we know about the impact of taking all of these recreational drugs and Truvada on top of that on the body or on the organs or kidneys or livers? Do we have anything around that?
So, thank you for the question. I think it's an important question. Our trials that included gay and bisexual men included gay and bisexual men who use a variety of substances, as you indicated. We did find that PrEP drug levels were comparable among methamphetamine users as non-methamphetamine users, and the same thing with cocaine users. There were enough cocaine users that we could see that PrEP was highly effective for them, and that adherence was possible, and that drug levels were as expected. And that was true for methamphetamine and cocaine, and for that matter, marijuana. For some of the other designer drugs, I could really say that, I can only say that we don't expect there to be any drug-drug interactions. Tenofovir and emtricitabine are eliminated by the kidney in a very simple manner, whereas the other substances that people are using typically are processed by the liver. And so because they're processed in very different ways, we don't expect there to be drug-drug interactions. So, we expect PrEP to be highly effective. It certainly was in the PROUD study, in the IPRGAY study, and in the IPREC study. These studies did not exclude substance users. They were all welcome. And so I think the information so far is encouraging.
Excellent.
If I can just jump in there for a minute. If somebody's using a number of other drugs and has a strategy where they're going to use condoms in the heat of the moment reliably, then they're probably going to have more of a risk of not using their condoms under the effect of all of those other drugs than their Truvada that they've had every morning with breakfast, because that's going to be on board. And I think that's one of the safety issues. It's not about, I'm not talking drug-drug interaction, but as far as the provision of protection, it's protection that you don't then forget in the heat of the moment because it's already on board.
Excellent. Okay. Well, look, I'm conscious of the time. You haven't had dinner, and these people are actually going to be captive in the foyer. So what I would encourage you to do is take further questions up with them. I've also seen the list of questions that have come through the email address. So what I'm going to say to you is that a bold thing, ACON will have a look at those questions, and we'll see what we can do around putting something online or doing some Q&A, answering those questions in some other way following this forum, and we'll try and promote that as widely as possible. A few thank yous. Ashram and ACON want to thank you all for attending tonight, for your attention, your thoughtful questions. I'd like you to join me in thanking all of our panellists and speakers. I don't know about you, but I never have met someone in the who's been voted by Time magazine in the top 100 most influential people in the world. But if you want to get his autograph, chase him down now. Join us in the foyer. We need to be gone out of here by 9 p.m. That's when our rent expires. So enjoy your evening, and thank you again.